Okay, so I'm Marcia Cleos, president of this wonderful sisterhood at the Highland Park Conservative Temple Congregation Anshe Emet, and I'm going to introduce Helene Nee, who is going to introduce our speaker.
Okay, no
All
problem.
yours.
Thank you and welcome everybody. I am so pleased to be introducing my dear friend, Dr. Yvette Schlussel, who received her MPH, MA, and doctoral degrees from Columbia University. She was an assistant professor at New York Medical College and St. Vincent's Medical Center in New York, and supervised community health studies, screening for cardiovascular disease, breast cancer, and physical activity in the elderly, among other public health issues. She actually received a grant from Pfizer to study the impact of social support on improving women's healthcare access to needed services. Dr. Schlussel conducted research at Columbia University Medical College and Cardiovascular Center on women professionals who had work deadlines that affected their blood pressure. And interestingly enough, for married women with children, their blood pressure did not have the typical fall after returning home from work, because then they took on their second shift duties. She worked in the Department of Family Medicine at Mount Sinai Medical Center, monitoring residents on conducting research in reproductive health, low-income women, health service utilization, diabetes management, in clinical settings, and improving access to prenatal care and assessment of the nutritional status in community settings. For the past 20 years, Dr. Yvette Schlussel has worked at Rutgers University Department of Nutritional Science, studying the #1 health risk facing women in modern industrialized society, and that is osteoporosis. She's working on ways to recruit more women and minorities into clinical trials, a topic very relevant to today's presentation. And I'm really summarizing a huge resume here. And as we can see, Dr. Schlussel is an experienced researcher, expert statistician, seasoned teacher who has quite an eclectic skill set. You probably know her from her healthy cooking demonstrations that she does regularly for Hadassah, where she's known as the chef's daughter. Please join me in welcoming Dr. Yvette Schlussel, who is presenting on the topic of women's healthcare disparities.
Thank you, Helene, for that very nice introduction. And thank you for inviting me to your workshop on social justice and women's health disparities. And I thank everyone for attending. I'm grateful to have this opportunity to share with you what I've learned over my career as a cardiovascular epidemiologist and a professor in medical settings, teaching residents, serving some of the poorest populations in New York City, and as an expert witness in discrimination cases. So this is all like distillation of what I've learned over this long career, and also some of my more recent work as a teacher in clinical trials management and the ethics of clinical research and the recruitment of women and minorities to those kinds of studies. So I want to share my screen. Let me and start the slideshow. Can you see it? Hello? Helene?
Yeah, I was just going to say, if anyone has a question, please put it into the chat. I'll be monitoring the chat, and Dr. Schlussel will answer as we go along if you'd like. So you don't have to wait till the end. If something is concerning or pressing, please let me know. And I think Marcia, you'll have to make her okay.
And I just wanted to know if you could see the screen.
No, not yet.
Oh, really?
Yeah, we just see you with your lovely background.
Oh, okay. Well, okay, now it's
now we see it. Yeah.
So this is just my title, and I'd like to start off with a question, and that is, do we need a Me Too movement for women's health? And the most important question that I'm really going to address this evening is The way women's health symptoms are dismissed in the medical community by physicians, by other healthcare workers. And, you know, this is a cause for much of the problems in healthcare and disparities for women. And I just like to introduce with a story that I read recently in the Washington Post about a 24-year-old woman, Hannah Katan, who went to 10 doctors for 3 years who told her her abdominal pain is caused by stress and overweight. And finally, she managed to see a doctor who who did a scan that showed that she had a tumor the size of a volleyball in her ovary. And during chemotherapy, she wanted to share her story, and in the hopes that it can help others who have their pain dismissed. So the very high number of messages she got from other women seemed to suggest that many, many women have this same kind of experience, that they've been brushed off by doctors and told that it's their weight, hormones, menopause, and other things. It's all in their heads, and that's causing their pain or their other health conditions. We know a lot about breast cancer, so I'm not going to focus on that. And I'm also not going to spend a lot of time talking about the main populations that are affected by women's health disparities, namely poor and minority women. But I will mention them at some point. And I would like to focus on ovarian cancer because of this recent case. And also because, you know, as a sisterhood, I'm sure you want to know some more information about that. It is the second most common gynecologic cancer in the US and causes more deaths than any other cancer among American women. The proportion of hereditary ovarian cancer is much higher in the Ashkenazi community. And most of this is accounted for by inherited mutations in the BRCA1 and 2 genes, which account for 29 to 41% of ovarian cancer. Only 10% of ovarian cancer is attributed to mutations of these genes in non-Ashkenazi. In the US, 1 out of 345 and 1 out of 1,000 carry a BRCA1 or 2 mutation, compared with approximately 1 out of 40 individuals of Ashkenazi Jewish descent, both men and women. So it is very common in the Jewish community. And the ovarian cancer risk associated with BRCA mutation has been reported to be as high as 66% for BRCA1 and 27% for BRCA2. So why is there no screening test for high-risk women, women at high risk for ovarian cancer? So we have a blood test for the cancer, the CA-125 tumor marker. There's also ultrasound or a combination of the two. But there are problems with each of these tests. The CA-125 tumor marker is a protein that's higher in 80% of women with ovarian cancer. And it's commonly used to monitor women with ovarian cancer. But it's also high with a variety of other more common conditions like endometriosis, fibroids, liver disease, pelvic infections, and other cancers. So CA-125 levels are also higher than normal in 1% of healthy women. So it's not by itself a very good standalone screening test. And pelvic ultrasound has also been used in combination with CA-125 as a screening test. But ultrasound can't always tell the difference between ovarian cancer and other more common conditions. And there are many false positive ultrasound tests leading to unnecessary surgery and other problems. Very recently, just last May, the largest study of ovarian cancer screening done in the UK, over 200,000 women, that where they combined these two tests showed that it really still, the final results showed that the screening failed to save lives. And which meant that the researchers needed that in order to find cancers even earlier, they have to study much larger populations. There is an ongoing clinical trial for which compares two surgical procedures in women with the genetic mutation of BRCA1 for cervical cancer and for ovarian cancer, and I'll give you the details of contact information at the end. Who's at risk for ovarian cancer? It mainly develops in older women. About half the women who are diagnosed are over 63. And it's more common in whites than in African-American women. And you may be familiar with the famous Jewish American women who we have lost to ovarian cancer. Gilda Radner, Madeline Kahn, and Janet Margolin. And as I said, the survival is actually very poor. The prognosis for ovarian cancer, there's only a 49% 5-year survival rate, which is close to, the poor survival for brain cancer. So just as, an introduction, I'd like to review what are these women's health disparities and what can we do about them? And some of them have to do with barriers to access, while others are differences in diagnosis and treatment. So in barriers to access, this tends to affect all women, but especially African-American, Hispanic, Native American, Pacific Islander women with limited resources, geographic barriers, language, literacy, women who come from traditional communities whose family members have to accompany them to medical visits. These are all significant barriers and delay and sometimes limit access to healthcare. For example, the lack of access to prenatal care leads to greater risk of complications in pregnancy, delivery, and even infant mortality. The lack of access during the pandemic may have contributed to maternal deaths during pregnancy and the first 6 weeks after childbirth, which rose during the first year of the pandemic in New York, especially among Black and Hispanic women. And here's the infant mortality rate, one of the prime rates that's used to characterize a country's healthcare. So in the US, it's 5.6. It had been getting worse over the, from the late 1990s. And as you can see, it's much higher in Black and Pacific Islander American Indian women. It's almost twice as high. And unfortunately, if you look at the international standings, the US doesn't do very well. It's sort of in a neighborhood with Eastern European countries. Most of the Western European countries and some Asian countries are actually doing much better with infant mortality. Access problems can also lead to delays in diagnosis. And here I'd like to thank Helene for sharing a patient history that I'm going to just recall with you. So you can, get a sense of what barriers to access are all about. Robin was a 32-year-old single mother of a daughter with autism. She'd been working in daycare for several years and had no private health insurance coverage, only Medicaid. She had abdominal pain and went to get medical care. She went to an urgent care clinic, which advised her that she had stomach problems and did nothing to treat her. After several months, she decided to go to a neighborhood clinic where they ordered tests. And when it was revealed that her HCG level was high, the doctors kept assuming that she was pregnant. She told them she wasn't pregnant, and she said it's not possible, but no one listened to her or took her seriously. As her disease progressed, she was always tired and had chronic abdominal pain. And then she was referred to a different specialist. So after several weeks, first she went to see a GI doctor who told her she needed to go to a GYN oncology consult. Since she didn't have the right insurance, only Medicaid, she waited for a specialty clinic visit at the cancer center. This took more time. Finally, she went to a GYN doctor, and after exam and more tests, it was found that she had a choriocarcinoma, a form of uterine cancer, which had metastasized to her liver, and there was no treatment available. So for her, the delay in timely medical care or the difficulty in access cost her her life. So as I said, this is the major problem where, you know, this gender bias doesn't take women's healthcare complaints seriously. And there are other diseases where women's complaints are not given equal attention. Heart disease is the #1 cause of death in US women, but only 22% of primary care physicians and 42% of cardiologists feel well prepared to assess women's cardiovascular risk. The bias in detecting and treating heart attacks has led to women having significantly higher mortality than men, and thousands of deaths in women could have been prevented had care been equal. Every minute counts when during a heart attack, but men get rushed to the catheterization lab quicker than women. This is called the DORP to balloon time, so that doctors can open a blocked artery. Osteoarthritis is the most prevalent chronic condition among women, but doctors give less medical information about total knee replacements to female patients who have knee pain than to men. These are all results of empirical studies that have been done in these different diseases. And I'll tell you in the next slide about women who present to the ER with acute abdominal pain have to wait longer than men to receive pain medication, an average of 65 minutes compared to 49 minutes for men. Autoimmune conditions, you know, women they're blessed with robust immune systems. They have higher longevity, but this also means that they have many autoimmune conditions. So for example, more than 40% of women eventually diagnosed with serious autoimmune diseases had at some time been told by a doctor that they were just too concerned with their health. I became interested in gender bias in healthcare when I was an NIH fellow at Cornell Medical School and heard a female cardiologist, Nanette Wenger, give a talk about bias in diagnosis and treatment of heart disease in women. For hypertension, the national guidelines recommend the same approach for treating hypertensive men and women. However, current US antihypertensive medication use and the resulting degrees of blood pressure control are different among hypertensive women and men. Hypertensive women are significantly more likely to be treated than men, but less likely to have achieved good control. Until 1996, trials of treating mild to moderate hypertension were conducted on middle-aged men, and most decisions regarding hypertensive treatment for women were based on data obtained from trials done predominantly on male patients.
And Yvette, there is a question that came in on the chat, and it's, do studies show that female doctors do better with female patients than male doctors?
Well, with hypertension, it's interesting. Women are more likely to have white coat hypertension with male doctors, meaning their blood pressure is elevated in the clinical setting, but when 24-hour blood pressure monitors became readily used, it was found that at home their blood pressure was normal. So they are reactive to the clinical setting. And I'm not sure about the question about whether there's less, but I have read something about that the patients in certain operations did better with female surgeons recently. I can't recall the type of operation, but they had better outcomes. So that's my, but maybe we can save some of the other questions for later. For heart disease, women, as I said, women are more likely to die within the first year after a heart attack. After that, it kind of stabilizes. And the reason why is that women tend to be diagnosed later, treated less aggressively with surgery and interventional procedures like bypass operations, and they're less often prescribed medication and referred to cardiac rehabilitation programs. Even though heart disease is the #1 killer of women, the symptoms sometimes appear as less life-threatening in women. So they may be like acid reflux. Most of the heart attack signs that are portrayed in the media and taught to patients don't display in women, like chest pains and pain in the left arm. Women tend to experience symptoms of nausea, fatigue, or back pain and not realize they're having a heart attack. And that since these symptoms are common in other conditions, they're diagnostically challenging to doctors. In diabetes, men are more likely to receive a diagnosis of diabetes than women. But diabetic men tend to be more thoroughly treated compared to women. Men with diabetes have been found to be more likely to receive oral combinations of drugs such as ACE inhibitors or calcium channel blockers in the presence of coronary heart disease as compared to women diabetic patients. And as a result, women with diabetes may be more likely to develop complications than men. And some of these advance their disease to heart disease, kidney disease, stroke, and depression. In pain management, as I mentioned briefly before, in one study, women who went to the emergency room with severe stomach pain had to wait much longer than men with the same symptoms. They were less likely to receive opioids than men, even after controlling for other known risk factors. And gender bias was concluded by the authors to be an explanation for this delay. And possibly standardized protocols might improve this discrepancy. Another issue with diagnosis is underdiagnosis. So there are many common diseases that are more prevalent in women, but they're underdiagnosed or undertreated. And this includes PCOS, fibromyalgia, chronic fatigue syndrome, lupus, MS, rheumatoid arthritis, IBS, and thyroid problems. Another patient history kindly provided by Helene. A woman named Ellen, a 40-year-old high school guidance counselor, had been in fairly good health until one day she felt numbness in her left foot, but didn't give it much thought. A few months later, she started stumbling, tripping over her feet. Again, she really didn't think much about it. She just thought she was tired from work. She was concerned enough after this continued to consult her family doctor, who said it was due to anxiety or stress. She was having work problems. One of her colleagues had been harassing her, but the symptoms persisted. And finally, she was feeling much more tired than usual and couldn't do anything when she got home from work. So she went back to her doctor, who ordered blood tests. Of course, they didn't reveal anything. MS is quite a difficult disease to diagnose. And finally, a friend suggested she go to a neurologist, and after more tests and an MRI, she was eventually diagnosed with MS. So now she's getting the treatment that she needs, physical therapy and drug therapy, and she's doing better, but wishes that she'd been taken more seriously when she first went for care. Another issue with diagnosis is overtreatment. In the US, 20% of women undergo hysterectomies unnecessarily. In one study done in Michigan, 40% of women that underwent a hysterectomy were not presented with alternative methods of treatment prior to the surgery or had alternatives tried. The review of the pathology reports of the 52 hospitals in the state found that nearly 1 in 5 women didn't, their medical reports didn't support the need for the hysterectomy. And over 37% of the women that did not need the hysterectomy were under the age of 40. The C-section rates and induced labor rates continue to rise. And this is also to some extent associated with overtreatment. Internationally, cesarean section is associated with being a migrant to another country, language barriers, low SES, poor maternal health, gestational diabetes, high BMI, fetal-pelvic disproportion, and inadequate prenatal care. But in the US, it's kind of like we're living in this, treating women like we're in a third world country, where the cesarean section rate has increased from 4.5% in 1965 to 24% in the early 2000s, and it's currently 37%. A large proportion of cesarean section confers risk without providing medical benefit. And there's also starting to be an uncontrolled international pandemic of medically unnecessary cesarean section births. In the US, C-sections are, the rates are highly correlated with region. The states with the highest rates share a high percent of poor women, African-American or immigrant women, ethnic minorities, with no or delayed prenatal care, a high percentage of language barriers, and high percentage of women with low education and lack of access to care. But on a lot of studies were done that showed that besides the regional factors and the women's factors, when you hold all those constant, there are other factors, including physician practice patterns, that explain the high rates. There are very low, cesarean sections are really the result of a low priority of enhancing women's own abilities to give birth. The decision to do a C-section is often done during labor, and they're usually among first-time mothers when they're not really ready to give birth. Also, they're considered a side effect of common labor interventions like electronic fetal monitoring, having an epidural, or having an epidural without a high dose of oxytocin seems to increase the likelihood of C-sections. Many women with previous C-sections would have liked to have the option of a vaginal birth after cesarean, but they're not given that choice. Many of the variations are due to practice style, the guidelines followed in the particular doctor's institution practice. And some of these are based on economic issues. There's a much lower awareness now of harms associated with C-sections. You know, mothers are not informed about risk of surgical cuts, infection, blood clots, and many of these things before birth. And the incentives to practice in a manner that's efficient for providers has really, a lot of the more recent literature seems to suggest that the flat global fee method of paying for childbirth doesn't provide any extra pay for providers who support long vaginal births. So they opt for C-section because they're more efficient. And finally, many providers' preferences for work-life balance means they're really unwilling to attend births at night and on weekends, and they schedule more births by induction and C-section for weekdays. Now, I'm not going to go into a lot of information about disparities in women's mental health, but I'm just going to give a very quick overview and then maybe some historical information. Mental disorders, you know, have been shown to affect men and women differently. Depression and anxiety are more common in women. Women are at greater risk for inflammation-related depressed mood and other neuropsychiatric, neurodevelopmental, and neurodegenerative disorders during reproductive years, especially in the midst of hormonal transitions. And these hormonal transitions are in perinatal depression, premenstrual dysphoric disorder, and perimenopause-related depression. Women may also experience schizophrenia and bipolar disorder differently. Certain symptoms tend to be more common in women than in men. Just a little background on the history of mental health and women. Just about a century ago, a husband could have his wife committed without either a public hearing or her consent. So many women were committed to insane asylums in the 19th century that the hospitals were overcrowded with hundreds of patients squeezed into a few wards, and hundreds more were on waiting lists. Chloroform and ether were used to quiet boisterous women, and sometimes not only temporarily. And if drugs and straitjackets didn't work, there was also always surgery. The theory ran that women's sexual organs caused their madness, so cutting them off would calm them. And doctors claimed a 70% success rates. Other treatments of the era included removal of ovaries, injection of ice water. The only way to escape this was to submit. Elizabeth Packard, an educated inmate at one of these asylums, grasped the harsh reality and wrote, "If women remain true to their natures, there's no hope for them." So according to this 19th century psychiatry, female independence was considered madness. And this woman, Packard, was a mother of 6 and, you know, committed to an asylum by her husband, where she wrote a memoir. And their main complaint was that they were causing annoyance to their family and defying all domestic control. Women who studied or read or simply had minds of their own and a determination to use them were demonstrating eccentricity of conduct, which meant they were morally insane. So the US doesn't have a very good history with mental illness in women. And is it any wonder why women raised in traditional patriarchal societies, especially ones in some places in the United States, are afraid of speaking up? But there are alarming rates of mental health needs currently in pregnant and postpartum women. Mental health conditions are the most common complications of pregnancy and childbirth, and suicide and overdose combined are the leading cause of death for new mothers. This results in over 700 deaths a year. Women are not given grief counseling over miscarriages. And screening and treatment for postpartum depression are widely recommended, but unevenly implemented. For example, post follow-up visits after delivery are usually 6 weeks later, and that's really too long to start screening women for postpartum depression. As a result, some of these treatable perinatal mental health conditions can have long-term, multi-generational negative consequences. I'm going to talk a little bit about political action and women's health disparities, especially what's changed. The Affordable Care Act has improved access for women. Before the ACA, women experienced sex-specific challenges in obtaining and affording health insurance and health care. They were excluded from health insurance or charged higher premiums compared to men for pregnancy, for past pregnancies, if they had a history of receiving infertility treatments, or if they had experience with sexual assault or intimate partner violence. Women are dependent on health insurance. They're more likely to receive health insurance coverage as a dependent. But life events like divorce or loss of a spouse impact women's health insurance access much more than men's. Women are more likely to need and utilize healthcare than men, and they're more likely to report taking a prescription medication or having a chronic illness. There have been many attempts since the Affordable Care Act was passed to repeal it. What would repeal of the ACA do? It would reduce access to contraception. This includes emergency services, hospitalization, pregnancy, and mental health and substance use disorder. And there have been over 70 Republican-led attempts to repeal, modify, or curb the Affordable Care Act since 2010. For many years, states have chipped away at reproductive rights with regulations and restrictions that left Jackson Women's Health as the only provider of abortions in Mississippi. In a few months' time, the Dobbs decision is likely to be handed down when the right to an abortion, as Americans have known, may no longer exist. Supreme Court justices say that abortion may once have been thought critical as an alternative to contraception, but this is no longer the case since birth control is more available and reliable. But this is an inaccurate assumption. Why? The United States, alone among industrialized countries, doesn't mandate paid family leave. Many women have to disrupt work, even if they're single mothers, to care for children. The major advances in women's access to careers and to the public sphere have occurred since the early 70s when abortion was legalized, and it's likely that the two developments were related. Even with reliable access to contraception and to childcare for all, people still want and should be able to exercise agency over intimate, life-transforming decisions of when or whether to have children. And many women will still need to end pregnancies for reasons like health crises and health risks to their lives, destructive or failed relationships, personal economic hardships, and the needs of other children that have nothing to do with the social conditions that the justices talk about. There are facts of the Dobbs case that I'll just briefly review. In 2018, Mississippi passed a law called the Gestational Age Act, which prohibits all abortions with few exceptions after 15 weeks. This Jackson Women's Health Organization, the only licensed abortion facility in Mississippi, filed a lawsuit in federal court challenging the law and requesting an emergency temporary restraining order, which was granted, and the court precedent prohibited states from banning abortions prior to viability. the U.S. Court of Appeals affirmed, and the case will be decided in 2022. But in May of last year, the governor of Texas, Greg Abbott, signed legislation to ban abortion at 6 weeks of gestation, so early that women may not even know that they're pregnant. And this law went into effect this past September, virtually banning abortions in Texas. And the cruel twist of this law is that it allows anyone who's opposed to abortion, regardless of where they live or whether they have any association with a patient, to sue an abortion provider or anyone who helps a patient obtain an abortion by providing financial help or transportation. So what can, I don't want to end on a negative note, but what can we do to counter gender bias in healthcare? The number one thing is to speak up. Don't dismiss pain and health concerns, especially when they're chronic. Have an advocate. If you're shy or quiet, don't like to complain, or are intimidated by medical settings, bring along trusted family members or friends who can ask questions, request services, demand services, fill out forms, or help you with insurance forms. You can volunteer to advocate for others. Many hospitals have patient navigators who assist patients with complex care needs. And you can donate to organizations who advocate for women's health equity. What can we do to improve gender bias in healthcare systems? We can help them recognize gender bias. The first step is to acknowledge that it exists, and it's also imperative that their patients are aware of gender bias and ask the right questions of their care teams. We can conduct more research involving women. Many research studies into diseases and treatments, as I mentioned previously, were skewed with a higher number of male participants. Even with the Healthcare Revitalization Act, which prohibited clinical trials from excluding women, didn't get more women to volunteer for trials. It's still a great difficulty, and it's also very difficult to get minority group members to volunteer for trials. Ensuring that women are properly represented in medical research will help alleviate this gender bias, especially with development of new drugs. And we can also educate healthcare professionals. Outreach programs to help healthcare organizations address gender bias will help make professionals more aware of bias and how it manifests. It's also important that medical teams understand how certain health issues can present differently in men and women. So I'd like to read a few quotes by some prominent women about women's health access. By allowing women around the world access to family planning tools, communities would see increased health, economic development, and gender equality. Madeleine Albright says, when women are politically and economically empowered, the entire society's health, education, and economic situation benefits from it. And Isabel Allende, the Chilean writer, says, in order to see real change in the world, we need feminine energy in positions of power, and we need to nurture the feminine energy in men. So my solution to this is that the hope for the future depends on empowered women and on women getting involved in organizations that support women's health equity. And here are some of these organizations that you can contribute to, volunteer for. The information on that clinical trial for ovarian cancer. And I want to thank everyone for their attention and for coming.
Wow. Okay, thank you as well. And in the chat, we did have a comment from one of our women participants that said that she had a C-section with her first child and was among a movement of women who advocated for and had a VBAC, which is a vaginal birth after cesarean, their second child, and that was back in 1994. So women's voices were and have been heard, because I certainly know many other women who've been in that same category, and that was really helpful. You know,
Yes.
I don't know if anybody else has a question. You can certainly unmute and ask a question, or write it in the chat if you prefer.
I just had a couple of comments. I used to live in Sweden, and in Sweden I had 9 months paid leave for every child, which you could divide between husband and wife. And not only that, but your job was guaranteed for a year and a half after your, so you could not lose your job. And I came here, just could not believe, my aunt worked for what do you call it, the National Institute of Health, and she got three months, and she was excited about having that. And I just could not, you know, it was hard to imagine, because it's, and of course, all healthcare in Sweden is free, quote unquote free, after you pay huge taxes. But I did not pay a cent for 3 wonderful babies and and stays in the hospital. So it's the United States is incredibly behind the rest of the world, as you pointed out. It's really frightening. But and I also just had one other little vignette. I was seeing a doctor for pain and intestinal pain in Sweden, and he just kind of laughed. He just kind of laughed and said, "Oh, it's just FFF." And I said, "What's FFF?" Fat female over 40. And I just never went back to him, obviously. What a comment to make, though. What a horrible
Right.
thing to say. But obviously that's what they were thinking. You know, you're just complaining about it because you're overweight. Nice thing to say.
Yeah.
I was
And,
shocked and never went back to him.
and as I
Anyway.
said, that's not very uncommon in even today.
Right. And here's a question. Are there any local hospitals or organizations prioritizing women's health disparity or women's issues? Well, I can kind of answer that, at least from where I work at St. Peter's. We are definitely attuned to women's healthcare and women's healthcare disparities. We actually have a midwifery program that's very active. And I have a feeling, I don't know, maybe you can confirm this, Yvette, that women who do have midwives in their care perhaps have a lower rate of C-sections than women who, you know, are going just to regular OBGYN.
Yeah, unfortunately, the studies of that are not, haven't been well controlled. Women who, they're sort of like a bimodal distribution, and that women who use midwives, they tend to be healthier, more affluent, or they tend to be in areas where few doctors are available. So there's 2 different distributions there, and the ones that are in areas where more there are fewer doctors available, you know, may not have as good outcomes because they lack other types of care, the supportive care before and after, and you know, the other cases where the women who go to midwives, they tend to seek them out on their own, or it's the practice of the medical institution to use midwives. And they're usually used not for high-risk pregnancies.
Right, I guess
So
that's
they have better outcomes, but it's because they're, you know, in healthier women.
right, self-selected. We also
Yes.
had a program with doulas, which are people who help women during their, you know, pregnancies, or actually during their deliveries. And I know that that was an ongoing study that was, you know, used to try to assist women as well.
Also, can I say something for Women's League? Actually, I'm on the resolution committee for Women's League, and we're actually in the process of putting together a women's health disparity resolution. So, and I think Hadassah also does a lot pertaining to that too.
Yes, I had them both down as, you know, organizations to join to continue the work of advocating for women's health equity.
I have some other suggestions of things that people can do. including find somebody that will help you make a list of questions before you see a provider, even if it's what you would consider a routine visit to a doctor you know. Sometimes having questions or things that you just need to update the provider about written before you go helps you think it through. Helps you think about what you want to focus on and what's important to you. And in a very similar way, there are people in the community, myself included, who will go with somebody to an appointment and either take that list and help remind you if there's something you missed talking about, or just take notes. If you're going to get the results of a biopsy or you're going for some other kind of important appointment, sometimes it's very overwhelming and you think you understand and you think you heard everything, and you get home and you go to call a friend or talk to a spouse and it's like your whole mind goes blank. And if somebody else was there and they just took notes and you have something to fall back on, you're more relaxed, you're a better listener. You may not even need those notes. My third suggestion is listen to the younger generation. A lot of us have daughters, daughter-in-laws, granddaughters who will come home and talk about things they're learning, and they're getting a very different set of information than at least the women whose faces I can see and I know that are in the videos tonight. My mother was involved for many years in a project where she went into high schools and relatively low income public schools and did presentations through Hadassah on breast cancer and self-exams. And the young women would go home and leave literature on the table around their apartments. They lived with multi-generation female families. Basically, there weren't men around. And the number of women showing up in clinics would go up very quickly, people coming in for screenings. But I think the same works in reverse. For those of us that are a little bit older, we're attached to people that we trust and that we communicate with who are younger, who bring home new information. And we could really benefit on that if we open our ears.
That's a great suggestion.
Thank you.
So I have a comment. My daughter, I told my daughter, who is a millennial, about tonight what the discussion was, and first thing out of her mouth was the pink tax. Anybody ever heard of that?
No.
So I said, what is that? And she said, it's the tax that we have to pay on all the feminine products that we have to buy. And added to that is, why should we have to pay for all those feminine products that we have to buy? You know, tampons and sanitary napkins and all that kind of stuff, which is a whole nother topic of conversation.
Marcia, it's actually the best thing you can do if you're going to donate to a shelter, to donate those feminine products. And if you have one of those old, you know, you go to Clinique and you get those free bags, stick them in a bag because they don't have anywhere to put them. And it's always something very, you know, very wanted and needed in those shelters and places like that.
Well, I know. It's just a shame that that's the case. Like, why should women have to pay for all those necessary things to begin with? Why doesn't insurance cover it?
Well, look at the disparity between getting a prescription for Viagra and getting a prescription for birth control.
Right.
It's now, it's gotten better, but let's say 5 years ago, you could call a hotline, an 800 number, and a purple pill or a blue pill or whatever color it is would show up at your doorstep. But if you needed birth control, it was, well, you need to go to Planned Parenthood and you need to this and you need to that. Now you can, there are services you can call up and get birth control over the phone, but it wasn't 5 years ago.
Right. Agreed.
There was an article in the paper yesterday or the day before about a woman who had a miscarriage and went to a Catholic hospital where they allowed her to bleed way, way beyond what she should have, because I understand that they have to do a D&C to complete the miscarriage. She was not complete. And it was just really very disturbing. Now, Helene, I know I love St. Peter's. I think it's a great hospital. But if I were pregnant, I think I would be a little bit hesitant about delivering a baby there or going there for any kind of women's issues that has to do with
Yeah, well, Ellie, I can tell you that wouldn't have happened in that. I cannot ever, ever imagine anything like that happening at St. Peter's, where we are a teaching hospital. We are one of the top women's healthcare providers in this state. And no, that would absolutely, I can positively tell you that that would not happen, and no woman would have to fear. We deliver over 6,000 babies a year, and we do things right. So there wouldn't have been a problem with that. And just another comment that every single area, every single part of the hospital and every single division of St. Peter's has a social worker associated with it. And we as social workers are healthcare advocates. We are there, we're the spokespeople, we're the people that can help with that list of questions that Ann Cheryl had talked about, with kind of speaking up for people who can't, or just don't even know the right things, and, and being emotionally supportive as well. So supportive on all levels.
Okay.
So, yeah,
I
so
think St. Peter's is a great hospital, but I was so
Right.
disturbed when I read this article because
Yeah.
St. Peter's is a Catholic hospital.
Yes,
And
we
I normally I would have no problem with it, but this thing just really rankled me in
Right.
terms of
I
women's
think that's an outlier, honestly. Yeah.
Okay.
So I know personally somebody in Florida who just had a miscarriage, and she was not in a Catholic hospital, and she was left without having her D&C in a timely manner, and it was very serious, and it was a mess. So fortunately, all is well in the end. But I will tell you, Ellie, that in the 60s, when I had my children, I was nervous about going to St. Peter's for the same reason that you're saying, especially since I had a section the first time, and I knew I would have to have a section the second time. And I was very afraid that the hospital would handle baby first, not mother. And I already had a child. And I was more concerned that my child needed a mother than a sibling.
Yeah.
So I understand exactly what you're saying, but
Yeah.
I was assured then by my family doctor that I was 100% wrong, but he still honored my wishes and got me somebody who, and sent me elsewhere so that I would feel comfortable. But he told me even in the 60s that really wouldn't happen.
Okay. All right.
No, absolutely not.
Sometimes you read something that's an exception.
Yeah.
That's really why I
I
asked.
have a different question.
Yeah.
As a senior, I was very taken with all of the information. I've heard a lot of it before that Dr. Schlussel gave about cardiac care and cardiac treatment being uneven between men and women. And I've noticed that if I'm searching for a cardiologist that's a female, I don't see too many names. I don't know if that I can see any names at the moment that I've heard of anybody. Every cardiologist I know of in this area, and I'm probably don't know them all, but they're all men. And I'm inclined to feel that women probably treat women differently, and I would feel more comfortable with a woman. But are we really having a shortage of female cardiologists?
Well, there is a lot of sex segregation in certain specialties in medicine. Most orthopedic surgeons are male. Most, as you said, cardiologists are male. And there's something about certain specialties. I don't want to say that it's they don't recruit women, but they make it difficult for women in those specialties. I knew one female cardiologist in a group not far from here who she left the group. I think she couldn't talk about it, but I think that her colleagues might have made her life very difficult. So I don't think that it's unheard of, but I think you'll have a hard time possibly finding some, and it has to do with certain practices or and to some extent self-selection. But yes, there is a lot of sex segregation within the medical profession.
And Yvette, there's some other questions or comments. It says, wondering what you think of Dr. Fishman's 12 yoga poses versus osteoporosis. Are you familiar with it? It's interesting to me that a male doctor did and is still doing research on preventing and reversing osteoporosis, but nobody has heard of it. Maybe you've heard of it.
I'm very familiar with it. Have it printed out as a yoga instructor, not yet practicing, but just recently certified. I do those poses. When I presented them to my colleague Sue Shapsis at the Nutritional Science Department at Rutgers, she said that they haven't been empirically tested, and it's not a controlled trial. So Dr. Fishman believes that they're helpful, but the study that the 12 poses are based on was a study of about 1,000 self-selected women, who participated, who I guess wrote in to, did an online survey and were monitored. And it wasn't a clinical trial. So the results, need to be tested and in a randomized fashion in order to be more credible. Which doesn't mean you shouldn't do them, but as I said, it's hard to say whether they're really good for maintenance or prevention.
And yeah, I mean, certainly worth even using as an adjunct,
Yes.
to some of the other medications or other treatments, right?
Right.
It certainly can't hurt, I think. And there's another comment about stroke and heart attack symptoms being different for females. And I think that you had brought up some of the symptoms for women.
Yes,
might be
right.
different. And I think, yeah, there was a talk earlier last week about this very topic, if I'm not mistaken.
Actually the Women's League had a cardiologist in Houston speaking on that topic, and you could probably, once it's posted, go to the Women's League website and find the conversation, or YouTube at the Women's League site.
Yeah, that's sort of well known, but not widely distributed. So I think people still tend to look for the clinical signs that are more known about in men, the chest pain and the left side weakness and things like that.
Right. Luckily, one of our, I guess, members of our synagogue was fortunate enough that when she woke up feeling horribly nauseated in the morning, that her secretary told her that a cup of tea was not going to do it and that she should get herself to the ED, and she did, and is happy to tell that story. So we need to be more aware of those things for sure. Okay. And any other questions or comments that anyone wants to make here?
Can I jump in?
Sure.
Can I just jump in real quick?
You bet.
So as a female physician, all of the things that are being said are so very true. And as a female patient, I've been on the receiving end of some of these things. There actually was this study where patients, male and female, did better with female physicians. I don't remember the study off the top of my head, but it was definitely there. In terms of one of the things that Ann Sherrill said about bringing someone with you, I write things down for my patients. And if you don't have somebody with you, ask the doctor to write it down, because you're going to walk out and not remember what was said. It's really important, especially if you're getting new information or something like that. So, I love the fact that you're here doing this. And it's more information needs to be out there. There are some really good female cardiologists. I know one in Hamilton who's phenomenal, but there are fewer than certainly the male cardiologists. That's definitely true.
Thanks for sharing. Anybody else? Okay, if nobody else has anything, I know we have just a comment, a very nice program, and thanking us for the program. And we certainly appreciate all the time and effort that Dr. Yvette Schlussel put in presenting this really phenomenal program. And, you know, if there are any other suggestions or recommendations for programming, please do get them to the committee members, which include myself or Susan Winter or Cindy Patridge. So, okay. But thank
Great
you.
job.
Very,
Great job, ladies.
thank you.
Thanks, Yvette,
Thank
for
you.
all that hard work.
Thank
Well
you.
done. Well done. This is the best committee that we've ever had doing this. Really. No committee beforehand has ever
Never
done this successfully.
No, thank you. Okay.
Great
All
job.
right, so everybody be healthy,
You-
okay? And don't be afraid to speak up, right? Because
Right.
Oh, yeah.
indeed, that's exactly
And
what
and bring an advocate.
is change,
Yes,
right?
bring it up.